Hello, everybody, and welcome to tonight's MHTV. We're really pleased to have Kate Wales with us tonight. Kate's a colleague of mine, and she's going to be talking to us about the role of restorative clinical supervision. And we're talking about that specifically in a prison health injustice context. But first of all, before Kate introduces herself, we'll go over to Nicky, who'll just say a few words about how you can join in tonight. Okay,
Absolutely.
Nicky?
Hello. We're going to be talking about a lot of subjects that I think you're going to find very interesting, very useful. So please feel free to join in. If you want to contact us via Twitter, just use the hashtag MHTV, and I'll be keeping an eye out, and so will Dave, and we'll gather your questions together. If you're watching on the Facebook live feed, please feel free to comment, ask questions, and we really want to hear from you. So do get involved tonight. Thank you. Vanessa?
Thank you. Okay, so as I said, tonight we're going to be talking about clinical supervision and the role of the professional nurse advocate in the health and justice setting. So Kate, we'll go over to you if that's okay, just to introduce yourself to everyone and say a few words about your work at the moment.
Thanks, Vanessa. Thanks, Nicky. So I'm a registered nurse by background, and I completed the professional nurse advocacy course in June last year. So in May this year, I was seconded into a 6-month project role. My brief was to embed a positive supervision culture across health injustice, and implement the role of the professional nurse advocate as well. So I think it's important to say that within Practice Plus Group, we currently have 48 prisons and 2 immigration removal sites. So it's quite a big site nationally. So when I was looking at implementing the project, this isn't just nurses, it's looking at implementing clinical supervision across all disciplines, which is multidisciplinary. The project's broken down into 3 phases. So phase 1 was scoping out, so really looking and understanding what supervision looks like at the moment currently. What are the barriers? What are the facilitators to effective supervision, clinical supervision? Phase 2 is looking at culture change and implementing supervision and the role of professional nurse advocate. And then phase 3 is evaluating the project, seeing what works, what didn't work, and learning from our lessons.
That sounds really interesting. So tell us a little bit about the professional nurse advocate course for people who might be listening and might not know much about it.
Yeah, so I had a really positive experience when I did my professional nurse advocate course. So I did it at Northampton University last June. It's a 10-week master's level 7 accredited course. So the professional nurse advocate role is a leadership and advocacy role, and they deploy a model called the A-Equip model, which is advocating for education and quality improvement. So the role really focuses on providing support to the individual's health and well-being, guiding and supporting them through education and training. And then the really exciting element of the model is working towards quality improvement. So it's very much focused on Proctor's reflective model. However, there's an additional element to that, which is supporting a quality improvement project within the organisation.
Yeah, it's obviously really important, isn't it, in the setting that we all work in.
There's an element to that, which is the restorative practice, which for me, as a registered nurse, I've always been a reflector and reflecting upon my practice. However, completing the course just led me down a completely different route and allowed me to really think about supervision and actually the restorative approach. And it really focuses on the staff's individual needs, what they want, improving their health and well-being and building upon their resilience. And especially more so within health injustice, they're faced with such difficult, challenging situations that the restorative approach, I personally think, is the right way to move forward within health injustice.
Yeah. So when you say the restorative approach, are you talking more about looking at the impact of situations on people's well-being as well? and being able to talk about that in a supervision environment.
Yeah, so it's really looking at the emotional needs of the staff. So it's very much an employee-led model. So it really focuses on their health and well-being, and to equip them with the tools and the techniques to kind of build upon their resilience and professional and personal development as well.
Yeah, and would that be done in a group context or an individual context, or are there different types of approaches?
So I think not one size fits all. And especially when I was doing the grounding work with starting the project, I've held lots of focus groups and sent a survey out across health injustice. And what was really apparent is that people like a different variety of models. So some people really flourish in a one-to-one situation. Some people prefer the group work. Some people prefer peer-to-peer. And obviously there's benefits and obviously challenges to each of them. So it's a variety of different models in which whatever the individual chooses to partake in.
That's really interesting. Nicky, any comments from social media at this point? Or from yourself? No, should we come back to you in a minute?
Yeah, sorry, I was pressing the wrong button to unmute. What an amateur after all this time. I'm trying to tweet and answer questions at the same time. I do have one question so far, and it's from somebody who's only ever worked in the community. So I guess you're a student nurse. Thank you very much. It's good that you joined in. And what she's asking for, I think, is a little bit of clarity around what's special about the type of area you're working in. So she's wanting to know a little bit more about what's particular about that, because I think the comment she's made is that it's tough all over. So, yeah. So if you could give that information, that'd be really helpful. Some context for it.
Oh, you're on mute now as well, Kate.
Sorry, choice of technology.
Go for it.
I absolutely agree. There are challenges in all different areas across nursing. I think what's for me, obviously, experience working as a nurse within health injustice. Our nurses are exposed to emotional labour in terms of they work in really emotionally challenging environments. And there's elements of potentially compassion fatigue, the malignant alienation, because they're exposed to a really vulnerable patient group, where there's high self-harm, there's trauma, and actually that can really impact on an individual. There's also the enablement issue. So you've got the challenge of enablement with accessing the patient versus the nurse's professional accountability, which obviously then takes us down the lines of moral injury and the quality of care that the patient receives. So we know as nurses sometimes not having access to the patient, and sometimes we know that what is right, but actually we don't always do the right thing because of them enablement and challengement issues. And
Let me stop just for a second. Just go back a tiny bit, because I can see this lighting up. So for start off, you're talking a bit about moral injury. Could you just unpack that a little bit, and we'll go through each of the terms maybe so people can see.
Yeah, so moral injury, in suppose in a simplistic term, is that when we know morally and professionally what's right, but actually when we're faced with challenging situations and the vulnerability of patients, and one of the examples I use is around the enablement issues and access to the patients, we don't always act in the right way, or we might not say the right things because we're exposed to challenge and trauma within the environment that we work in.
Yeah, I think as well, what's important for people who haven't worked in prisons to understand is that it's not like when you work on an inpatient ward when there's nurses there with the patients all the time. And as Kate says, there's an access issue that in an acute ward, you would have access to patients, you would work on a shift with people. In a prison, the health team's very much a guest in the prison services environment. So it's a completely different context. Yeah. So it's about kind of often seeing patients by appointment. It's not like just being able to pop in and say hello. You're influenced by things like the prison bringing people over to healthcare at certain times of day and then them having to leave at a certain time because it's part of the regime for them to go back at that time. So there's all kinds of other complexities. And I think for me, as well as a mental health nurse of 20 odd years, you know, we've always been, if there's a critical incident, you're usually the first in there, but in a prison, that's not necessarily the case. The prison, it'll be the prison officers who are usually the first in there, and then we're called over. So we're very much part of a broader team rather than the healthcare team leading the situation. That's how I see it anyway.
That's really helpful.
Yeah. So yeah, so really the potential for moral injury is a totally different context, I think, to working outside a prison environment. Like Kate says, we know that it's challenging in every environment, but I think there are like really unique challenges to work in a health and justice setting. And also, and Kate's mentioned the level of trauma in a health and justice setting is often quite extreme as well. And, you know, for nurses who are exposed to that constantly, and that becomes very much the norm. So I think, yeah, I mean, at this point, it might be interesting to talk a little bit about compassion fatigue as well, because I think that's an issue, not just in health and justice, but across the health service. But I think it really links to this particular conversation, doesn't it?
And I think we know, like you said, Vanessa, the staff working within health and justice are exposed to sometimes really emotional, really traumatic, challenging situations. And if that was to continue on a regular basis without any form of supervision or support for that individual, then obviously that's when staff start to burn out. You see the compassion fatigue come in, they're tired. And I think that's why the restorative element really helps with that, because it really opens up that flexible, open, honest, confidential approach to supporting that individual. So in terms of compassion fatigue, that's something more so now post-COVID, because we had really high incidences of positive COVID patients within health and justice. And actually, we really struggled accessing resources and things like that within the organisation, which really led to staff being really tired and a large proportion burn out. Yeah.
So do you think, I mean, I suppose this is very individual, but I wonder if there's a link between kind of people burning out and being less willing maybe to access supervision at that point, that maybe we need to have a supervision culture much earlier than that, because once people burn out, that's when people's sort of emotions can become more blunt. Their kind of emotional responses are very different.
Yeah, I agree. I think organisationally, it's got to be a culture change. There's got to be a shift in terms of it's my right to have supervision, and it's the right thing to do to look after our staff. So, and we know that actually research has shown, and living and working within health and justice, that actually supervision or clinical supervision is probably one of the first things that gets dropped from the diary when there's an incident or there's high workload levels, and it's not prioritised. And that's the culture shift and the culture change that I really want to try to improve, is that we need staff to access this. And we talk about high turnover and recruitment and retention, but if our staff are working in environments that are hard and they're constantly being challenged and they're not happy to come to work, we're going to see continuously the high turnover. So we've got to make our workplace a nice place for people to come to want to work, and supervision is a key element of that.
Yeah, I think that's really important, because I think we focus a lot as well, don't we, culturally in the NHS, full stop, around the people who are off sick, but actually it's often the people who continue working when they probably should be off that we should be reaching out to and offering some support.
Yeah. And the restorative approach allows for that. So the restorative supervision can work with staff that maybe have been on long-term sick and starting to do a phased approach and coming back to work, to start to kind of build upon their skills as well. So there's so many different elements and dynamics
Yeah.
that actually you can tap. So it's not just about reflecting upon someone's practice, but also there's other elements to restorative supervision and the role of the professional nurse advocate that can support with.
Yeah. It's interesting. Nicky, any more questions? I notice you've got your head down there.
I've got a question. Well, it's not really a question, it's more of a cry for help by the sound of it. It's what is malignant alienation, and then 3 question marks and a face. So make of that what you will.
So I'll answer that first, and then Vanessa, I'm sure you'll have another interpretation because of your knowledge. So
no pressure.
Malignant alienation is something where, so for example, within health injustice, as we've spoken about, we're exposed to really vulnerable patients and really high, challenging, demanding situations. And actually what you find sometimes is that the relationship between the patient and the professional can sometimes, that therapeutic relationship can sometimes break down. And actually what you see is the professional acting probably not as professional or in a professional way that you would expect to see because of the demands of the environment or what they've potentially been exposed to. And that's how I interpret malignant alienation.
Yeah, so that's, I mean, I agree.
Explain that, right?
Yeah, absolutely. And I think within the sort of supervision context, how would you handle that? Because I think that traditionally, certainly in mental health, there's been a tendency that when somebody's struggling to work with a particular person, like they're pushing their buttons, it's having an impact in terms of how they're behaving, as you've just described, that people, change key workers and things, and people distance themselves, nurses, from working with someone who's quite difficult. So within this context, would that be a change of focus to more kind of looking at the issue and how it's impacting on the person?
Yeah, definitely. So from a restorative approach, like you said, it would be how it's impacting on the individual. So how did it bring them to that situation? And obviously there's lots of different tools and techniques that I would do as a supervisor with that individual. Certain things like the stress bucket, talking through that. So what are their triggers? What's making them feel and act in that way? So my focus would be on the individual and what's brought them to that point.
Yeah, it seems really relevant as well, doesn't it, in a health and justice setting? Because I know I sometimes get queries and questions from students about how do you work with somebody who's committed a serious crime and still maintain a compassionate approach? And I think, what you're talking about there answers some of that question, really, doesn't it?
Okay. Yeah, definitely.
I think what's particularly distressing about it is people go into nursing to help people. There's very few people that come into nursing with an intent to be the person that sometimes we end up as, be because we're tired, because we're overwhelmed, because the things that we were taught to cope and manage are just completely overwhelmed by the circumstances we find ourselves in. I think COVID has brought that on most nurses in one area or another. But I think there are specific issues as well in terms of the type of work and the type of trauma that the nurses you're discussing are exposed to. And I think as well, one of the things we were talking about just a bit off camera, which is always annoying, I think, to talk about your best stuff off camera, but there's this stuff around, there are certain types of nursing that are more visible or more heartwarming. So people will love a children's nurse. They'll love, somebody who is, frontline nurse or dressed as a nurse or looks like a nurse. But for the sorts of jobs that are slightly hidden or working with populations who are discriminated against or for some reason come across as less sympathetic to the public, those nurses get kind of like a reflected stigma as well.
Yeah.
I wonder if you've got any thoughts on that.
Yeah, well, like you said, we were talking about it off camera, and I suppose the example that I spoke about was kind of clapping for the NHS staff, and we had a massive cohort of not just nurses but allied health professionals that were working within the prisons, that were working with lack of PPE, all the things that the NHS were working with and the challenges they faced. But it was almost like they were a forgotten cohort, because people unfortunately don't really understand nurses working within health injustice and the challenges that they face. And this is why today is really great, because it gets us talking about that and raising the awareness of the role of staff working within health and justice.
Yeah.
Well, an epic question for you if you want to try it.
Oh.
What do you do? Someone has asked.
What do I do?
What do nurses do in prison? Yeah.
Oh, wow. So this is actually, I can answer this. So really, people don't understand the role of a prison nurse. And actually, it's so complex. You are so skilled because you are, and what people, I suppose, need to understand is in a hospital setting, you're supported by a team of medics that say when you have a cardiac arrest, you all run to it, and actually you've got a real team of medics around you that support one another. If you have that situation in a prison, you're quite often on your own and you're running to that incident and you don't know what you're going to face. And I've been in that situation. I've turned up and it's scary when you're on your own and having to deal with that. So prison nurses, they have triage skills, they have emergency response skills. You are assessing patients when they come in from off the streets, direct from court. They encompass a whole load of skills. And not only we're talking about primary care nurses, within health and justice, it's multidisciplinary. So you've got mental health nurses, primary care nurses, substance misuse nurses, and we've got allied health professionals, and we've got GPs, psychiatrists, psychologists. Yeah. So a really complex, multi-professional working group. Do you agree with that, Vanessa?
Yeah, and I think when I first worked in health and justice, what really struck me was that kind of multidisciplinary approach. And I know we talk about that, across healthcare, but kind of having a meeting at lunchtime where you have a handover and you've got not just other mental health nurses, but you've got adult nurses there, GPs, pharmacy, psychiatrists perhaps, and you can have a really holistic discussion about a person. And I think that is where health and justice nursing does shine compared to nursing in other parts of the healthcare system, having that opportunity. And of course that's necessary because we're working with the most complex patients, obviously, who usually experience the most inequality and have those sort of comorbid physical and mental health issues. But I think the practice of being able to bring everyone together is, I think, very different to anywhere else that I've ever worked. But of course, as Kate says, it's also very challenging, and there's that sort of collapse of primary care, secondary care boundaries, isn't there, in prison? So you're often, from a mental health point of view, you're assessing somebody, and they either they would normally sit within primary care. You might have that person on your caseload, but equally, you might have someone who's quite unwell mentally, and you'll also be supporting that person as well. And often working with people who are quite unwell, who need to be in hospital, and until we can get them into hospital, having to manage the person and support them in a prison environment, which is quite complex. So yeah.
We've got Shadrach saying I agree with you, Kate, so that's good. And hello to Victorious, who else is there? Alfonso, and some of the other regulars. So it's very lovely to see you back again, now alive. I guess it would be really helpful to understand how restorative supervision is different from maybe the other types of supervision as well, because some people haven't had any supervision, so it's all a bit of a surprise.
Clinical supervision tends, this is my experience, tends to be very much led by the supervisor, and it's very much a focus on a particular clinical incident, and you talk about potentially, or you reflect upon something probably that maybe the supervisor wants to talk about potentially. It's quite structured, and it's quite prescriptive as well. So where that differs to restorative, with the restorative approach, it's very much a focus on the individual's health and well-being, and equipping them with the tools and techniques to be able to deal with certain situations, for example. You've then also got the managerial supervision that is obviously very much focused on the person's professional development, so things around career development, talking about annual leave and appraisal. So obviously and that's one of the challenges as well, that staff don't understand always the difference between managerial and clinical supervision, and there's a real lack of misconception of what the two are. So often people will go into a supervision session and not understand the purpose of why they're there, and that, I think that's one of the barriers, not just within health and justice, but speaking to other staff external to Practice Plus Group, is that the skills of the supervisor and the supervisee understanding what the supervision session is about can sometimes be a barrier to an effective supervision session, because staff don't understand what they're doing.
Yeah, it's interesting. I think something that's just struck me really now is, you know, as a mental health nurse, we're kind of trained and we work in quite a psychologically informed way, but other branches of nursing haven't had that training around being more sort of psychological. So I was just thinking in a prison context, as we say, where you might be the first professional on the scene to work with that person who's distressed, or as an adult nurse, you know, for example, you know, wound care nurse, building up a really close relationship with someone. So perhaps with a restorative approach as well, it's encouraging nurses to work in a more sort of psychologically focused way with patients, which I also think helps that mental health reach, that it doesn't just need to be mental health nurses that do mental health, that, you know, in the same way that mental health nurses need to have physical health skills.
Yeah, and the restorative approach would be a real focus on the emotional needs. So first of all, for example, with the way I would start a restorative session is a grounding technique, and that can be done in a variety of forms. It could be simply the open question of how are you, which opens up to lots of, you know, people can interpret that really differently. Or there's another technique where you can kind of just get the person to really relax and kind of really think about their surroundings, their smells, the sounds, and it really brings that person down and gets them to relax, which then hopefully will lead to a productive restorative session for that individual. And it's a real positive way, like you said, Vanessa, of reducing that individual's stress. And I think, like you said, where I think there's been a history of mental health nurses do this really well, and psychologists, and I think this opens us up to a lot of opportunity across the organisation, and it doesn't just sit with mental health nurses. My approach is that it will be a multi-professional model, so we've got paramedics, we'll have occupational therapists, we'll have GPs engaged with it, so it doesn't just sit with the mental health teams.
It can be a belief as well, rather than the reality sometimes for mental health nurses. They're much better at doing it for other people than they are about realizing it for themselves. And I think that what you were talking about grounding is really important, because one of the things I've noticed in my career is the amount of times where you really disassociate from yourself. When a situation is really stressful and traumatic, you don't physically process it, you know. And then we hear colleagues who are exhausted, who can't sleep, who are sort of experiencing like unspecified pain, anxiety, and it's a lot to do with the fact that, you know, a lot of the supervision on offer, it just isn't conducive, it's not flexible enough for people's needs. I wonder if you have any thoughts about the importance of flexibility and personalization in supervision.
So the approach, my vision is that it will be a clinical supervision framework that's underpinned by restorative supervision, and ultimately that will be a multi-professional model that is flexible in its approach. So, for example, we have a serious incident that our staff are exposed to, then there will be available restorative supervision for that individual straight away. Not all individuals work like that. They have to process it, think about it. So that could be a more planned, structured restorative supervision. And what I do before the restorative supervision is send out an emotional trigger form to staff, and it gets it just some questions. And I don't want to see it. I would never ask to see it, but the staff would. It makes them think about where they're at the moment, and actually they can bring that to the session if they want, or they don't have to. But it's almost gets them thinking about where they are at the moment and their emotional needs as well. So like you said, Nicky, I want it to be a flexible approach, because at the moment what we see is every 6 to 8 weeks we must have supervision. It's done, or we're told in certain situations that this is our supervisor, and it's so important that we have a really good therapeutic trusting relationship with our supervisor. Otherwise you're never going to be honest, and you're never going to open up and trust that person. So it's absolutely got to be a flexible approach, and that's a two-way relationship, both with the supervisor and the supervisee.
That's interesting.
More questions, if that's all right. Emma Dillon says that sounds great, Kate. Getting a lot of love, Kate, for that tonight. A lot of affirmation. You should be recording.
Emma Dillon was my module leader. She was the module leader at Northampton University, and she was amazing.
That's nice. Hello.
Alfonso says, is there a limit on who should have clinical supervision? Is it mainly for senior nurses? And Nicky Simbani has asked, I think we agree that clinical supervision is still not understood, because to me, clinical supervision should have the restorative part, and it should be supervisory led, which is absolutely what we're saying. Adrian Jugdor saying clinical supervision is only as good as the supervisor, which is an interesting point. And I guess if we don't invest in supervisors, they're always going to have this issue. I found the better ones are often non-health related, because they can ask questions in a way that make you rethink your approach. They don't understand the health related assumptions, and when you need to explain, that actually helps you figure out yourself, think a little bit as well. So that's really helpful.
What's interesting is the comment around it's only as good as the supervisor. And interestingly, at the start of this project, I sent out a survey, and there was a really strong theme that one of the barriers to effective supervision was the skills of the supervisor. And that's where we need to go back to looking at what the skills of the supervisor are. They equipped with the tools and techniques to be able to support that individual as well. So that's something that will be a focus for me. So that's really important.
That was going to be my next question, actually, because we've talked a lot about the actual supervision, but how are we going to skill up people to be supervisors? How do you envisage the sort of professional nurse advocate?
My vision, like I mentioned, would be having a strong clinical supervision framework underpinned by the restorative approach, which is then complemented by the current clinical supervisors and the professional nurse advocacy, so the P&As as well. So what I want to do is upskill and train the different staff within the regions around restorative resilient supervision, so they're then equipped with the skills and tools and techniques to be able to deliver effective sessions. But that will be complemented and supported by the role of the professional nurse advocates within each of the regions.
Yeah, so do you think that'll be presumably multidisciplinary clinical supervisors? So one of the barriers at the moment is that we focus on nurses, and we have a large cohort of staff that aren't accessing supervision because we focus on nursing staff. So my model needs to be multi-professional and multidisciplinary. Yeah, I agree. And I think having some multidisciplinary supervisors might help with that, mightn't it, as well?
It gets you thinking in a different way as well, doesn't it? You know, if you're supervised potentially maybe by a paramedic, it's just an example, they think about things differently. They may have a different way of thinking about things, different skills. So if it can be multi-professional, it allows us to develop both personally and professionally. Yeah.
It's interesting. Another thing I was thinking about was documentation, because that's one of the things people always worry about, isn't it? Oh, if I talk about this in supervision, it's going to be documented and it's going to get back to my manager and I'm going to get into trouble. So how will you overcome that?
So restorative supervision, you don't have to document anything. You don't have to document it. Obviously, for the organisation that I work in, there will need to be an element of capturing the number of sessions that we hold for restorative supervision, and also that would have to be fed back to NHS England as well as part of the professional nurse advocacy role. So what my current P&As are doing are that they will complete an evaluation form. They will complete a form once they've done the supervision, both them and the supervising. It will just detail, nothing confidential, but the themes. And that will provide me with the qualitative data of how well the project's going as well, and maybe what we need, what we're learning from it as well. So the good thing about restorative supervision, there isn't a requirement that we record anything.
Yeah, that's good.
There is the expectation at the beginning of the session that you have almost an agreement, a contract, you know, in terms of if there was anything of any risk that potentially you might need to escalate, then that's discussed, and kind of, you know, kind of what's expected and what's not expected. So like an informal contract, but there's nothing that needs to be written down.
Yeah, and I'm assuming, so tell me if I'm right, that the clinical supervisors will get supervision from the P&As, and the P&As presumably are part of a wider network of P&As, is that right? So
my vision is that the clinical supervisors will have support from the professional nurse advocates. So we've currently got 25 within health injustice.
Amazing, isn't it?
We've which is spread out nationally. Yeah, we've got higher numbers than other organisations, which is really positive. And obviously, we're just hoping, fingers crossed, to securing more places, because we've had lots of other interest. And so obviously to try to get to the 1:20 ratio as well that we want to get at the end of the 3 years. So the clinical supervisors will be supported by the professional nurse advocates, and then the professional nurse advocates can then tap into the regional resources and myself for supervision as well.
Yeah, that's great. And for anyone watching who might now be interested in being a professional nurse advocate, how would they go about inquiring into that?
Yeah. So there's lots of really great information on the I think it's the England.ac, what is it, England.nhs website, I think. So if you just type in professional nurse advocate, there's lots of information and resources on there, really a good wealth of information. Also, if staff can access the e-learning for health website, and there is a free module on there which staff can access if they're thinking about doing the course, that talks about the role of professional nurse advocate, the AE Quit model, which will obviously guide them and help them if they want to take part in the course as well. There's also, which is an amazing resource, the NHS Futures platform that staff can access, and on there is a discussion board, the different regional P&As, and a wealth of information and resources that staff can download and access as well. So there's lots of information out there should staff, or if they're thinking about doing the course.
Yeah.
Really helpful. Hannah Davis has just almost asked that question. Really done. So is there a structured framework for clinical supervisors to guide their sessions to ensure certain topics or questions are covered?
So there's lots of different frameworks out there and models that staff can use, and there's prompts. Even if you literally go onto Google and you can type in clinical supervision frameworks, clinical supervision model. Honestly, my brain was overloaded when I started this project. There's so much information out there, and actually there isn't one specific definition of clinical supervision. Researchers, there's so many different, when I was just trying to get one definition of it, but there's so much research out there that if you just Google it, you can find your way around the internet, and there's lots of different kind of frameworks and models that people can use should they want to.
Yeah. Brilliant. Anything else? I'm just conscious we're coming to the last 6 minutes already. It's flown, hasn't it? I mean, we always said it.
One question's come in, if that's all right.
Yes, please.
So, where did P&As come from? I've never heard of them. So, well, thank you for your honesty. I won't say your name.
So the professional nurse advocacy role has been running for just over a year and a half now, and it was introduced, or Ruth May, the Chief Nursing Officer, introduced it as a thank you almost to the nurses during COVID and post-COVID, because they were obviously faced with challenging situations, demanding situations and adversity, that it was brought in as almost a thank you. As a way of supporting our staff and supporting their health and well-being during it and post-COVID as well.
That's good. Yeah, and if is that it, Nicky, for you?
We've tweeted all the things that you've mentioned. We've tweeted out under the hashtag MHTV as we've gone along. And if anybody else wants to join in with resources they've got that are helpful, please just use the hashtag as well so we can find them. Thank you very much.
And Kate, we're just in the last 5 minutes, so are there any particular points that we might have missed that you'd like to get across tonight?
No, I think this has been a really good opportunity to not only raise the profile of the project that I'm doing, but the role of the P&A, but also to talk about nursing within health injustice as well, because it's a really exciting and challenging kind of situation to work in, but I love it. It's not for everyone. I absolutely love working with it within the prisons, and I think to raise the awareness and the profile of that is a positive opportunity.
Yeah, I mean, I agree with you, because I think one of the difficulties is people just don't go into prison settings, so they don't get to see what nursing is, and people have got a lot of preconceived ideas about what it's like in a prison. Kind of understanding the context of why people commit a crime, which is often related to trauma and inequality. And I think for me, once I actually ventured into a prison and saw the kind of, context of it, and understood what I could do and how I could help people in a prison environment, like you say, Kate, I love it as well. And I kind of, when I went to work there, I thought, God, why haven't I worked here earlier in my career as well? Actually, I think if you're committed to social justice, especially, it's the place to be, isn't it, really?
Yeah, I have a real passion for kind of the patient voice, letting them having a say, but patient safety and making sure that patients get the right quality of care, because they are our patients. Yeah,
I agree. I think we should possibly, I know Nicky's smiling at me because she knows I always get health injustice in whenever I can.
I like that though, it's important.
Yeah, well, I like to advocate for it, but I do think maybe we need to have a health and justice focused session, just talking about health and justice, so we might invite you back for that, Kate, if you're interested.
Definitely.
Yeah. Okay, any more questions?
Well, just to thank everybody who's joined in, really appreciate that, and to say good night.
Yeah, thank you then. Good night.
Good night all.
Thank you.